Well, thank you all so much for the opportunity to share a program director's perspective on robotic surgery. I am the general surgery residency program director here at UAB, and I followed in Marshall Urist's footsteps as he was the program director here for nearly 27 years. And so a couple of things that you'll see during my talk is a little bit about how we train residents in robotics here at UAB. It's not a 10-page curriculum. It's not a 100-page manual or textbook. It's actually pretty straightforward, and we'll show you a little bit about what that looks like here in Birmingham. I am fortunate to work with a great team. This was a group of our residents a year or so ago, and I couldn't do any of this without all of the residents, all of my faculty, all of our administrative support staff, all of our OR teams, and things like that. Because whenever you take a look at what's happened here at UAB since 2007 with one system which was originally purchased for cardiac surgery and then it sat in a closet for years and wasn't used, and then you're able to see it to evolve into in 2016, where now we've picked up two other XI systems here just recently, and I'm looking forward to you seeing those live cases tomorrow and see what that looks like. The residency program has to evolve with this at the same time. It's not like the faculty can get it and then we put the residents into it. The residents have to evolve at the exact same time. I like this perspective here just to give you a little bit of an idea of what does general surgery look like as far as where does it fit in the robotics pie at UAB. And it's interesting to see that we are a large section of it, and it's been like that for several years now. But it's not because we have 30 general surgeons that are robotic surgeons. I mean, this is a relatively limited number of surgeons. Dr. Cannon with colorectal, myself with general surgery. We have several others that are doing cases, but it's not, we don't have 30 surgeons doing this. So it's not something that requires you to have this giant bank of robotic faculty to get started for sure. So this adoption of robotic surgery here, whenever we think about where urology is now as far as their prostates, that there's no question that they have evolved all the way into the standard of care at this point. GYN oncology is close behind them, benign GYN right behind them, and general surgery is this opportunity to be in the forefront. And we're thankful to be in the forefront right now in developing the training for our residents. And so oftentimes we have this question of should we teach robotics, and I'll say yes, here's why. I've adopted this from Sharona Ross's talk that she gave at the Southeastern Surgical a year or so ago, where she and Dan Smith debated the topics of robotics versus MIS. And I love the way that she put this timeline together, and I think it really works really well. That if you consider that you've got 4 surgeons that are somewhere along this continuum of cases that are all done open, so it's that trauma surgeon, we're not going to be taking patients with 6 gunshot wounds to the abdomen, we're not going to be putting them in a robotic room, right? Even though we'd already have port sites, we're not going to be using that application tonight whenever we have something like that roll into our emergency department here. But then you've got the surgeon all the way to the far right who does everything minimally invasive. This is Dr. Dan Smith. He is a phenomenal laparoscopic surgeon. So how far is it going to push him? Probably not very far, because he's already done things that very few people in the world will ever do laparoscopically. So he's all the way so far to the right. And then the second topic to look at is what does it do to procedures? Okay, so we've got the trauma laparotomy, which we all laugh about. How would we ever do that robotically? It's really silly to think about. But it's equally silly to think about doing a laparoscopic doing a cholecystectomy open. It's the same argument. In the middle there, you've got low anterior sections, distal pancreatectomies, and things like that. So if we look at what does the robot do, I think the largest thing that it does is it moves surgeons down that continuum. Okay, so which letter are the residents, right? We're not recruiting these extremely facile laparoscopic surgeons out of medical school. These are coming in as very naive surgeons, and so I would argue that they're surgeon A, or they may not even be on this timeline. And so we're looking for the best education that we can provide for them, and we want to give them the best tools for education to be able to push them along that curve as quickly as we can. And we know that curve that surgeons can be pushed quickly along that curve. As we've already heard today, urology adopted to more than 50% of market share in 5 years. And now there's no question that urology is all the way to the far end. And urology was not driven based off of advanced MIS techniques 10, 15 years ago. But now they are doing some of the most advanced robotic techniques in the world, and so it pushed very quickly. The exact same thing is going to happen to general surgery residency programs. There's no question about it, and we are right in the middle of it right now. I wouldn't even say we're all that early right now, because there are a fair number of general surgery residency programs that have residents operating on the consoles, and they're pushing far beyond it. And I can tell you, as our chiefs are graduating, this is what the hospitals are asking the questions. How many robotic cases have they done? Are they already credentialed? Do they have the in-service training equivalency? I'll show you that here in just a second. Because they don't want to be hiring surgeons that then go off to an intuitive surgical course in Atlanta or Dallas or wherever like I did to learn robotics. They want to hire them already trained in a 60-month curriculum. And I think that that's going to be better. You can also see how it's pushed cases down the line here. You know, a Whipple 20 years ago would have never been even considered to have been done laparoscopically, and now we've got surgeons here in the city, we've got surgeons all across the country that are doing a procedure that would have been laughable in the 90s to do laparoscopically, but now it's being done efficiently and safely and quickly by several, many of them in the room here today. So we've seen this laparoscopic progression, this laparoscopic effect. I would argue right now that we are in this phase right now of the robotic effect with these advanced procedures that were all the way at the far left side of my original timeline, that they're now drifting because of this robotic effect. So how do we put general surgery residents into this, and how do we train them? And you've already heard it mentioned today about simulation, and I think this is absolutely essential that you have all of the simulation, whether it's simulation at the bedside with the instruments, with docking, with positioning and things like that. We do this in Saturday workshops. We do this training between cases, before cases, but the most important thing is this actual simulation, which you can see on that right side up there. I know many of you are familiar with it, but it's like a backpack that goes on the console. And this allows them to have all the different scores. And just like you saw Jaden, whenever Dr. Cannon was presenting, sitting down at that simulator, and Jaden can do this. My son, who's 15, got bored with this when he was 12. Because in about an hour and a half, when I was in a meeting and I set him down at the simulator, I came back and he was playing with his phone. He wasn't playing with a $2.5 million robot in the simulator. He was playing with his phone because he had completed the task that I told him to do, and he had scored very highly on them. So we require that they score 90% or better on several of these milestone modules which are in our curriculum. The most important one, I think, is called Ring Walk 3, which is in camera and clutching, and that's where you just have to take a little loop across a blood vessel. You go by 2 little tongues of liver. Requires you to keep all 3 instruments on the screen. And if you can do that and score 90% or better, then I'm confident that you can sit down at a console next to me, whether you're a medical student, whether you're a resident, whether you're a faculty member, and you can safely operate the instrument. Because I absolutely refuse to teach the operation of the instrument to a surgeon, to anyone with the patient asleep in a live case, because it's just inappropriate. We can learn the instrument without a live patient in the room. So if I ask them to kick the switch pedal and they hesitate and they look down at their feet, then I get to do the case. It's phenomenal because I love to operate. And that only takes like once. And they won't get to do it. I had a second-year resident on my service this year that didn't get on the simulator. They didn't do a single robotic case on my service for 6 weeks. Why? They never got onto the simulator. They didn't do it. That was a choice they made. It's a consequence. They didn't do cases. When they come on to Dr. Cerfolio's service next year, they're going to be behind. And it's going to show. But we're going to have to work with that as far as getting them up to speed on the simulator, because Dr. Cerfolio can tell you that one of the whole reasons people talk about cholecystectomy, whether we should do it or not, I would say absolutely we should do it. It's a high volume, low acuity case, and it has allowed our residents to dissect around the pulmonary artery. It's allowed our residents to sew the esophageal anastomosis with Dr. Cerfolio yelling at them in their ear and making them better and faster. But before that, it was impossible, because he can't have them do advanced cases if they don't already come into his service having done these high volume, low acuity cases. And so that's where cholecystectomy fits in for us. The simulator is essential for that. So what's come along? Martin Martino's here in the room. Where's Martin? There he is right there. The Robotic Training Network is a phenomenal resource that we have been able to partner with to be able to standardize this curriculum across the country so that programs are able to use that, because we have to have a standardized curriculum for our general surgery residents to be able to follow along. And then we also have to be able to have these benchmarks to assess where are they along this whole continuum. Included in this are these objective structural assessments of technical skills, OSATs, and then you can also see RSATs, which has also been validated here in these references that you can see below. And what does that look like? Just like the fundamentals of laparoscopic surgery, these are relatively straightforward tasks and with defined metrics that have been validated so that we can benchmark the residents and know how they're doing and be able to put that together. What's going to be really neat is going to be able to put this together across not just the United States, but to put this across all trainees across the globe with the Robotic Training Network, and what that looks like as far as being able to put this information together. And having trained at Mayo, I can't give a talk without some reference to Mayo. And this is one of my favorite quotes that W.J. Mayo gave in 1910 to the Rush medical graduates. And my favorite part is to say that in order that the sick may have the benefit of advancing knowledge, there's this union of forces that's necessary. This is a union of forces between industry, between academic surgery, between community surgery. This is a joining of forces of all these associations, all of these different groups to be able to put this together. And this is coming together in the Institute of Surgical Excellence as far as what this all looks like whenever we really get robotic training right for general surgery residents. This is coming down the line. I know there's program directors in the room we all cringe because there's another unfunded mandate that now we're going to have to get our residents through yet another fundamentals of something. But I think this is really valuable because we really do need to have residents up to that level of a fundamental working knowledge of robotic surgery so that they're not wondering where the switch pedal is. They're not wondering how to swap instruments and things like that. It's ingrained into them that they have to keep all the instruments on the screen and things that are just second nature once you've been doing robotic surgery. But we've got to be able to bring them up to this fundamental level of safety with robotic surgery. I've already mentioned this once. I feel very strongly that robotic training should take place within the confines of a general surgery residency program. We have them for 60 months. This is not like a one-day course. And so we're able to discuss in journal clubs, to be able to have basic science talks, to be able to have weekend courses and labs and things like that. We have visitors that come in here. Our residents learn from those visitors. We have our residents go with us to other courses for advanced things. I think it's so important whenever one of our faculty goes off to learn something, I've taken residents with me. And then they get to bring back that benefit to their colleagues, that what did they learn when they were at a course and that type of thing, because it's absolutely invaluable. The framework is already there. This is at least a year-old data right now. This 82% of programs having access to robots for general surgeons. I think that we're closer to 90% now, but I don't have that updated number. But the faculty that are in these programs are experienced. They have high surgical volume. They have all this experience with complex cases, and you really need that so that you can continue this conversation of where is robotic surgery best applied, what is the evolution, like for Dr. Cannon, what she mentioned as far as how her evolution was from beginning with robotic surgery and some straightforward cases, and then quickly realizing that this actually extrapolates to some of the sickest patients that she would have never thought originally would have been the best application. Multiply operated abdomens, the patient with the small bowel obstructions and adhesions like you saw in her case earlier. Those are the type of faculty that you need that are leading this and the residents are learning from. There is this incredible just sense of discovery that the residents get excited about it while they're learning something new. But this last thing right here, we're nearing, so February 24th, all the program directors in the country finalize their rank list, okay? And we have not pushed robotics at all to our applicants until this year. And we have kept that pretty much in the background. It hasn't been a real large presence on our website and things like that. But probably 3 years ago or more, applicants were coming to our program, and that's what they wanted to hear about. And so it's changed our applicant pool. We used to have about 550 to 600 applicants to our program. When we stopped checking the number of applications to our program in December, we had over 1,000. And out of those 1,000, there's 400 that are almost indistinguishable. Board scores in the 240s, 250s. We had 110 AOA applicants. We only interviewed 87. So we can't even interview all the AOA applicants. So it has really driven the applicant pool to take a look at these type of things. And if you're running a general surgery residency program now and you don't have a robotics curriculum and a process in place for these applicants, then they are going to be looking at programs that have it, because the number of programs that have it are growing, and it certainly has changed our applicant pool here, and I expect that it will continue to do that for years to come until all the residency programs are all on a level playing field. And that's where urology is now. Nobody advertises robotic urology surgery to their applicants, right? Every urology program in the country trains their residents in robotics. That's where general surgery will be, and I think it'll be there in a short time. I've talked about the faculty and their clinical experience. The most important thing right here, and you've heard it earlier, whenever I think Dr. Stifelman said that when he went and asked for the 5th robot or 6th robot, they were like, oh, okay, they got it. It was not a fight. And I think that part of what you'll see with that is that there is a relationship that you have to have with administration to be able to move forward, and you have to be able to listen to them, because there's times that they have to keep the lights on, and we've had meetings and discussions where we might be making a decision to delay purchase of something for the robot because we're replacing something from 1985 that's being used by every patient that comes through our pre-anesthesia clinic. We had a device that was working off of floppy disk. And this was like in 2014, and I think it makes great sense. We need to replace those machines that are working off a floppy disk before we purchase Firefly. I get it, but you have to be able to sit in their conference rooms. You have to be able to understand what they're doing, and they have to know that you really care for the entire institution to be able to move forward. This is Philip Harrington, who's a cardiac surgeon now, and he was my administrative chief resident this year, and this is exactly what he felt like whenever the questions came up, when it came up, okay, we're doing robotic surgery, because they throw up their hands, they think, oh my goodness, they're going to be doing these cases robotically, I'm never going to get to do it, so they first deny it. This is John McAuliffe, he's a fellow at MD Anderson now. He was the other administrative chief that year, and what they do is they isolate, so they go over to the electronic health record. They do everything they can to stay away from these cases, but they're there because they got to put in the orders. They're there to be the good soldier, to answer the question during the cases and things like that. But what really happens next is this right here, and they're angry. Okay, and where does this show up? Okay, this shows up in the ACGME annual survey. Okay, it is the absolute greatest weapon a resident has against the residency program, against the program director, the chairman, everything, because the ACGME, I think, has shifted. Used to be where we'd have site visits, and they would give us citations based off of site visits. They don't even do that. Our next site visit's in 2024. So they're not waiting on the next site visit, but they are looking at every annual survey under a microscope, and these surveys, which can have a huge the satisfaction of the residents can pull down the whole survey. And I think how you adopt robotics into your program, I think you need to do very carefully. And if you don't bring the residents along with them, or if you have this idea of we're going to get the faculty trained first, I can guarantee you're going to take a huge hit on the ACGME survey. Okay, we've experienced that. If you want to see what that hit looks like, we can show you, because it's real. But it can look as simple as this, right? This is not any different than me doing a thyroidectomy yesterday, right? I'm standing there across the table. We're working hand in hand to be able to get a thyroid out, do a lymph node dissection. This is the same thing. We're working hand in hand. Woody Farrington, our administrative chief resident for next year. This is when he was a second-year resident. And it takes him a lot longer, right? I docked that robot arm 3 times on that video, okay, in about 18 seconds. That was dock, undock, dock, undock, dock, undock. I did it 3 times. And he's still not got it docked, okay? And we're patient whenever we're teaching exposure, or we're showing how to move the spleen out of the way, or how to hold the liver, or how to set up a retractor. We're patient with that. we've got to be patient with some of these things about teaching docking and things like that. Now, that's not the first time he's docked. He's docked in labs, he's docked in weekend courses and things like that. But you have to be able to be patient to do that. And as program directors, you have to provide solutions for this process. How in the world are you going to bring the residents alongside the faculty? And this is it, right here. Okay, I've hammered the simulator, which is absolutely essential. But if you don't have dual consoles in your operating room, it's just not going to work. Because the amount of emotional energy it takes for me or any other surgeon to stand up, move out of the way, and let somebody else sit down and work is insurmountable. It just won't happen. Or if it does happen, it'll only happen 2 or 3 times in a case. Tomorrow, we'll see what it looks like for an adrenalectomy. I hope I don't swap the console any of the time. That might be great. The resident might do the entire case with me sitting there guiding with the cones, okay? And that might be a good sign that that resident's really good at doing a robotic right adrenalectomy. But I could argue that it's also might be a really good sign if I take the controls 18 or 20 times in a 1 hour, hour and a half case, because now I'm able to take the controls. Maybe I don't do any dissection, but I just adjust the instrument. I bend the angle. I lift something a little different, and they're like, I got it. And then I give it right back. So it's not a surrogate for how often we exchange for whether the resident's doing good or bad, but it does provide an opportunity for the residents to be able to, it provides an opportunity for the residents to be able to operate. And this video right here just shows how seamless this can be. This is Joe Karam. He's a trauma surgeon right now. And it's not just the residents that are going into surgical oncology or hepatobiliary. I mean, he's a trauma resident and he's learning how to do this. I think there is a little bit of audio on this one, as you can hear us chatting back and forth just a little bit. But I think one of the things that's really common is that since you're sitting side by side, you're often able to just to pause the operation for just a second and be able to kind of explain something, and then them able to go back to operating. And if we're having to swap back and forth between standing up and sitting down, and it just doesn't work. I think you're going to see that right here. So we're doing a left adrenalectomy, and I'm like, okay, Joe, this is driving me crazy. All right, I really want the wrist to look like this. All right, and he's like, oh, got it. You know, and then they can continue on working. You know, the other modality is to be able to teach at the screen. I can teach laparoscopy so much better with the robotic platform because of the console and those little triangular cones that are in 3D that I can move back and forth, as well as being able to stand and draw up on the screen. It allows you to be able to see all different types of things. Just to draw a V on a little pedicle right there, we use a simple little thing. At the bottom left of the screen, I can tap the erase button, and it will erase whatever I draw. But what I've done is we've taught the residents that if they hear and acknowledge what I've told them to do or what we've drawn on the screen, all they do is just tap that camera pedal. And so that just deletes all the drawings off of the screen. So it's this heard, understood, acknowledged feedback that I get in the OR to be able to do that. What's really funny is when they're tapping the camera to get the drawings off of the screen before I'm finished drawing, I get it that, okay, I'm talking too much. And they just need a little bit of time. They need me to slow down. They need me to be quiet. They need me to quit drawing on the screen, and they just need to work. Not that my mentor was impatient or anything, and that I didn't learn to do things quickly, but it's, you have to be patient with them, but you also have to give them a mechanism to communicate back to you that they got it. And then you got to give them time to be able to do it. I won't talk too much about physician extenders and dedicated OR teams. It's absolutely essential. If you left here with nothing else today, you have to have that. I think this picture right here, this is Alex Harrelson. He's the long snapper and specialty snapper for the University of Alabama. And I think we're doing a pretty good job recruiting him to our medical school with him sitting in a console. But I think it highlights pretty well the ergonomic problems if I'm swapping back and forth between me and somebody who's starting on the offensive line at the University of Alabama. That there's some physical constraints with the console that you need the dual console for. This is not intended for you to be able to read, but this is intended so that you can see how simple the curriculum is. Okay, it's in 5 years, it's in bullets, it's all printed out, it looks nice, and how Dr. Cannon has been able to be able to put this together, but there's just a couple of elements that happen in each year. And whenever we're sending out the very first announcements, welcome to UAB, congratulations, you've matched at UAB, there is a link along with 1,000 other things that they have to do to get a license in the state of Alabama. There is this link to the robotic online training. So we expect whenever they show up that they've done BLS and they've done ACLS, and then we're going to do ATLS whenever they get here. We expect that this is just part of that they've already done it. The Saturday workshops we've talked about, we expect that they do bedside assisting on 5 cases. This is typically on a colorectal service where they have junior residents doing these robotic cases, and they get many more than 5, but they get this so that they're not afraid of the robotic cases, they don't isolate, they're not angry about it, they're there, they're learning. And then the 90% or greater on the 6 milestone modules ensures us that we don't have to teach them about the instrument and how to use it. And so this is how it breaks down by the years. You see the first year it's docking and training. The second year they're with me with GI surgery, with pretty much cholecystectomies. But then they've got to be ramped up when they hit thoracic because this is advanced robotic surgery. Then in the 4th year, 5th year, it's very similar. Our 4th and 5th year residents are very similar. And so they see colorectal, surgeonic, HPB, transplant, and endocrine. And I really expect that they're able to do an adrenalectomy skin to skin by the time they finish. And I expect that they're able to teach a 2nd year resident through a robotic single incision cholecystectomy really without me. Because I think that really shows that they have mastered the technique if they can take a resident through a case. And this is just like we expected residents to be able to take junior residents through open inguinal hernia repairs when we trained. This is what we expect for them to do. This graph right here shows what our operative case numbers look like for the year. So there's obviously a graduated level of operative experience for our residents. This is what it looks like for their robotic cases. Okay, so they get a few cases in their 1st year, 2nd year, and 4th year. Their 3rd year, that's dominated by thoracic. And then their 5th year, they're really leading the procedures, like I mentioned, surgical oncology, hepatobiliary, colorectal, and those adrenal cases. I got a question at SAGES after a presentation 2 years ago. A very disgruntled community surgeon came up and said, well, this is just garbage because you're only going to be training residents to work with robots, and if they don't have a robot, they're not going to be able to operate. Well, this is what they do without the robot. And so we're really not talking about a massive section of their training. We're talking about 8 to 10% of their entire 60 months is focused on robotics, and I think that's pretty appropriate right now. But if you look at the fact that the residents are finishing with 88 console cases on average, that's phenomenal to think of what my expectations were when I started doing robotic surgery at UAB was to have 3 proctored cases. And it's really laughable that that was the expectation. So that's where our program is right now. That's where we're going. Once they've completed those robotic milestones, there's some more. If they do the minimum of 30 cases, which obviously you can see the average is at 80, they get that minimum of cases, then we create this letter documenting the completion of robotic training. And we think that's important because the hospitals want to have that, the fellowships want to have that. I'll finish with just 3 slides here of 3 last graduating chief classes. And you can see this 3 years ago, 2 going off to Jackson, Tennessee in private practice doing robotics. Hired 1 to stay here in plastic surgery. But these residents, so there's 3 that year that are continuing with robotics. The following year, you see MIS, colorectal, private practice, Vanderbilt MIS, MD Anderson, surgical oncology. You can see the trend of what's happening with our graduates, that it's also shifting the pattern of what do they do and where do they go. And it doesn't change. The only residents that aren't using robotics are residents that are proceeding into careers that robotics has not penetrated into yet. So I think the proof is in the product of what we're creating. When I first did single incision laparoscopic surgery back in 2008, I was so excited. We collected all the data, submitted abstracts. We were so proud, and my conclusion was that we did it. We figured it out, and we can teach it to residents. Do you know how many of my trainees do laparoscopic single incision cholecystectomies now? 0. Not a single one does it. I thought it was a success because we had figured out how to teach it, but none of them adopted it. The exact opposite has happened with robotics and general surgery, and it's coming fast, and we need to be ready for this next generation of applicants coming into surgery because they're certainly demanding it. And they're asking the question of, do we want to train at a program that's going to offer this robotics training during their curriculum, or do they want to go to a program where they're going to go out at the end and go to an industry-led course to be able to figure that out. So I want to thank you all for the opportunity to share our experience from an education standpoint.